A.K. Srivastava and Dr. Atul Kulshreshtha in theatre session. Dr. Anil Virmani.
Anil Virmani is a consultant physician from Jamshedpur. He has been ex-head of the department, Jamshedpur. He will be speaking on hemoglobin A1c from controversies to consensus. Dr. Virmani.
Honorable chairpersons, respected senior colleagues, friends, in particular Dr. Varish Nandar for inviting me here and sharing my thoughts with such an talented doctor. I would like to start with asking one simple question. Out of all doctors sitting here, how many of you do A1c in all your diabetic patients on a regular basis? Please raise your hands. Good, excellent. Okay. So, despite almost 35 years of his existence in the field of clinical diabetology, A1c is still mired in controversies. Well, controversies are part of life, as you all know, and everyone happens to fall into a controversy once in a while. Once my teacher pointed me with his ruler and said, at the end of this ruler, there's an idiot. I got attention after asking, which end? Well, friends, in the next couple of minutes, I'm going to talk about what is glycated hemoglobin, what is its role in the diagnosis of diabetes, in the monitoring, what is the blind spot of A1c, and how it should be reported. If you look at the position statement of ADA way back in 2004, they said monitoring of glycemic status is considered the cornerstone of diabetes care. And it is used to assess the efficacy of therapy and to guide adjustments in every part of monitoring and therapy. What are the problems with glucose management that we do regularly? The biggest problem is accuracy. We don't know in which lab, which blood sugar is genuine, how close it is to the genuine. What is the precision? Meaning thereby, can we reproduce the same result in the same conditions, in the same patient, in the same lab next time? And that is measured by coefficient of variation. The least the coefficient of variation, the highest the reproducibility, the highest the precision. And if you look at this, A1c has the least coefficient of variation as compared to postprandial or a fasting. Then there are technical problems in assays of plasma glucose. In fact, the way it is stored, the way it is done in laboratories, and it can lead to almost, a lot of studies have shown, it can lead to more than 12% of misclassification of diabetes. There are potential pre-analytic errors owing to sample handling. There is ability of glucose in the collection tube at room temperature, and this can shift the result almost from -6 to +7%. 8 hours of fasting may not be rigidly followed by all the subjects before going for a fasting plasma glucose or even an OGTT. And as you all know, OGTT itself is a very cumbersome procedure. So came the glycated hemoglobin, which was earlier known as glycosylated hemoglobin. It is nothing, it is but a non-enzymatic glycation of the hemoglobin moiety with a carbohydrate moiety, and depending on which carbohydrate attaches itself to the hemoglobin, various things are formed, HbA1, HbA2. But what we are interested is when glucose is attached to the N-terminal variant of the beta chain, it forms what is known as HbA1, and C stands for its particular position in the chromatographic column. And this is normally less than 6% of the total hemoglobin. If you look back at the history of A1c, it was way back in 1958 when it was seen in a chromatographic column, and 68 it was first characterized as a glycoprotein. 69 it was Samuel Rapper who observed its increase in diabetes for the first time, and again in 76 Anthony Cerami and Kinnick, they basically proposed that it should be used for the monitoring and the degree of control. Now, though it is said it represents the last 3 months of the blood sugar glycemia, it is basically 50% is contributed by the last 1 month before the A1c is taken. Now, elevated A1c levels are seen in a lot of conditions. But what is the correlation? Why do we want to do it? If you look at the correlation, the risk of retinopathy progression in type 1 diabetes is got an excellent correlation. Similarly, in type 2 diabetes, if you look at the microvascular complications, it has got an excellent correlation. The higher the A1C, the higher the prevalence of microvascular complications both in type 1 and type 2 diabetes. What about macrovascular complications? Interestingly, even at a normal A1C, the macrovascular complications like cardiovascular risk is almost 2 to 4 times than in a normal person and a non-diabetic person. But what is very interesting to note that even though when this cardiovascular risk rises with the rising A1C, it does not decrease with a decreased A1C. So there is no lower threshold risk. How well it does it measure? Well, this slide you must have seen hundreds of times. If you lower A1C by 1%, look at the drastic reduction in percentage of various microvascular and macrovascular risks. Of course, high A1C, the commonest cause will be a newly diagnosed diabetes or uncontrolled diabetes. But besides this, non-diabetic hyperglycemia, because of the various endocrine disorders, splenectomy, alcoholism, and low A1C will be seen in hemolytic anemias, whether congenital or acquired, in various forms of hemoglobinopathies, chronic blood loss, and chronic renal failure variability. One drug I would like to mention especially is dapsone, which has shown to give falsely low results. And people of Hansen's disease or dapsone, you should be careful when looking at the A1C levels. Now, it so happens that many times that you have an A1C report on one hand and you have a fasting or PP report on the other hand, and they don't match according to what you expect it to match. So, what is behind the scenes? If you look at the A1C and blood glucose relationships, if a person has an A1C of 6%, his mean blood glucose has a confidence interval ranging from 100 to 152. So a 6% A1C can have anywhere mean plasma glucose from 100 to 152. And a person with an A1C of 7% can have anything from 123 to 185. So there is considerable overlap between the two things. Moreover, the discordance can be because it does not capture glycemic excursions, which I will on later. There will be technical measurements variability, or in real phenomena like ethnic or racial differences and presence of a glycation gap. There are a lot of methods of measuring A1C. The gold standard, however, is HbA1c, and this is what some of the labs are following, because this was what the Central Primary Reference Laboratory measured A1C with. However, the ADA recommends that laboratories use A1 ACEs that are certified by the National Glycohemoglobin Standardization Program and traceable to the DCCT reference. That is very, very important to remember. And BioRad P10, which has been introduced in India, and a lot of good laboratories are using it, it gives us A1C quantification in the presence of hemoglobinopathies, optimized to minimize interference from various factors, and it is traceable to the ICC reference method and certified by the NGSP. So BioRad 10P10 is one of the machines that is used in good laboratories. What about A1C as a diagnostic criterion? If you look at the ADA guidelines, and this was 2007, not long back, A1C is not recommended for the diagnosis. 2007, what happened in 2 years? There was a committee which was convened in 2008 and they reported in 2009, and this was known as the International Expert Committee, and this was appointed by the ADA, the ESD and the IDF to consider the importance of A1C in diagnosis. And they recommended use of A1C for diagnosis with a cutoff of 6.5% or more. So if a patient has HbA1c of 6.5% or more, label him as a diabetic. And why was this? Because A1C was shown to have an excellent correlation with retinopathy, improved instrumentation and standardization of assays was seen throughout the world, there was less biological variability, greater pre-analytical stability, no requirement for pre-test fasting, and broad familiarity with A1C in diagnosis management, because we are using it for monitoring purposes for a long time. However, one must remember this before using A1C for diagnostic purposes, from where the A1C report is coming. Is it coming from a simple A1C meter, or is it coming from a laboratory which does not have any machines? So they have very, very specifically said that a diagnostic test should be performed using a method certified by the NGSP and standardized to the DCCT reference assay. Point of care A1C assays are not sufficiently accurate at this time to use for diagnostic purposes. An excellent study by Lee et al. From Korea, they made an ROC curve and they looked at the cutoff point and they saw that a cutoff of 6% had a very high sensitivity of 88 and a specificity of 80% compared to a cutoff of 6.5%, which had a very low sensitivity specificity. Moreover, this cutoff varied with age: 6%, 21 to 40, 6.2, 41 to 60, 6.4, more than 61 years. So they say diagnostic range is very different, cutoff values vary with age. So acceptance of A1C as a routine diagnostic test remains questionable. In another high-risk Spanish population, in more than 1,000 patients, they tried to diagnose diabetes by doing these three methods. And what they found? This was a high-risk population, and they found that by a 2-hour PG, they 8.6% of patients were diagnosed as diabetes. By fasting, it was only 2.8%, and if they used the A1C criteria, it was only 1.3%. So they said A1C alone diagnosed lower number of patients as diabetes and seems to be not advisable to screen for metabolic abnormalities. Why? There are great differences. We all know black persons have higher A1C levels than white persons, and this could limit the use of A1C. And there are a number of studies that are coming out with this technical differences. Again, should we lower the cutoff? The problem is retinopathy is more common at lower A1C level in blacks. So there is still a discordance whether what level we should have. So what are the clinical implications of using A1C as a diagnostic marker? You know, it offers greater convenience and accuracy than glucose measurements and correlates excellently with long-term complications. However, it may be too expensive for routine use in some parts of the world. Remember, it is not the gold standard for diagnosis of diabetes because no single assay can define the relationship between glucose and vascular complications. And once we start using it, the concept of pre-diabetes is going to go away in the next couple of years. ADA endorses committee recommendations on A1C in principle while evaluating the implications. Further studies are required to establish in other populations the sensitivity and specificity of A1C limits, the age-specific diagnostic criteria, and what should be the cutoffs. The best answer was given that A1C must be used thoughtfully and in combination with traditional glucose criteria when screening for and diagnosing diabetes, and this is published in the Journal of Clinical Endocrinology 2012. What about monitoring? We have talked about diagnosis, what is happening with monitoring. We all know A1C has got an excellent correlation with the mean plasma glucose. It reflects for the previous 2 to 3 months, of course more weighted in the previous month, compared to the gold standard of long-term glycemic control, and indicates change of therapy is needed. Is there an association between this and the SMBG? An excellent study again in more than 1,000 patients compared the correlation between A1C and the SMBG values. And what did they find? There was a very strong correlation between HbA1c and both pre-prandial and post-prandial. But what message I want you to carry home today is that A1C of 7% is equal to a pre-prandial value of 120 milligram and a 2-hour post-prandial value of 151 milligram. So those who are working in the periphery and do not have the advantage of getting an A1C done, if you can get your patients fasting to 120, their post-prandial to 150, rest assured you have achieved the goal of A1C of 7% in those patients in whom you have set that. However, remember, post-prandial values offer additional data for diabetic control. And as mentioned earlier by the speakers, as the A1C goes almost to less than 7.5, the importance of postprandial glucose becomes more and more important. Does A1C tell us the whole story? What is the blind spot behind the A1C? it does not track the glycemic response. And look at the A1C7 in a number of patients and look at the variation in glycemic profile. Even among the same patient, time-wise, from morning to evening, there is a lot of variation in the glycemic profile. So because A1C is basically an integrated measure of overall glucose exposure, patients with type 2 diabetes with similar A1C levels are going to have different glucose profiles. And we all know that intermittent hyperglycemia induces a higher degree of apoptosis and decreases the insulin secretory capacity of pancreatic beta cells than chronic hyperglycemia. Not to mention about the various hypoglycemic episodes that are going to happen. So glycemic variability is a very, very important unattended issue with A1C leaves out. And there is sufficient proof to know that the importance of postprandial and the glycemic variability has got a better correlation with oxidative stress as compared to A1C or any other measurement. So earlier we had the fasting plasma glucose, postprandial, and the A1C so-called triad. I think now it should be the tetrad, where we should be also measuring the glycemic variability, because if you want to get high quality A1C, minus the peaks and minus the troughs. How do we cope? There was a consensus statement by the FCC, ESCD, IDF and ADA in 2007. And they said, okay, now there's a fight between the Federation of Clinical Chemists and the ADA, so they joined hands together. They said now we should also report in the IFCC standards. So it should be currently expressed, reported as what is being used now percentage. The IFCC units in A1C mole per millimoles of HbA, and also in EAG, that is estimated average glucose, either in millimoles or milligram, and this was based on the ADAC study, the A1 derived glucose study. I don't want to go into details, but the figure that I want you to remember is tomorrow, what is 7% equivalent to is this. So 7% is equivalent to 53 millimoles of mole in IFCC unit, and 154 milligram in EAG unit, estimated average glucose. So if you're targeting 7%, just remember two figures, IFCC 53 and EAG 154. Most of the countries now are following dual reporting in both these units. In fact, if you want to publish a paper today in diabetes care, you will not be allowed to publish unless you report in both the units, and this is a message from the editors of diabetes care. This is from some of the prestigious labs, and look how they reported. They have not come up to what the current guidelines are saying. This is from another prestigious lab. And this is from one lab which is reporting everything. Dr. Virmani's lab, and I'm proud to say this is the only lab in India where I could find reporting in NDSP units, the IFCC units, and the estimated average glucose. And they have also mentioned what instrument they are using. No other lab in India is using such a reported gains. So what is positive for A1C and what is negative for A1C? Let's summarize. Positive, if you look at the biology, it reflects chronic glycemia. Agreed. The value is independent of acute factors like stress, exercise, short-term changes in diet. So patient cannot fool you. And it has got very low intra-individual variability. Negative, it has got variable glycation. We don't know how much hemoglobin is being glycated. There are variations with age, race, and variations with the lifespan of RBC. So there are some factors which we cannot take care of. Analysis, fasting is not required. Blood can be collected any time of the day. Sample remains stable. Assays are standardized and accuracy monitored in most of the good laboratories. Hemoglobin variants may interfere. Chemical modification of hemoglobin may interfere. Clinically, you can monitor long-term glucose control, used to guide therapy, predicts the risk of microvascular complications, and now also used to diagnose diabetes. May be altered by factors other than glucose, like patients on hemodialysis or CKD or severe iron deficiency anemia. There are new standards, there may be problems of acceptance and interpretation of results, there may be issues of lab compliance, the issues of point of care tests. Reputed hospitals from North India are using the A1C meters and trying to diagnose diabetes. Monitoring, no problem, go ahead. Not diagnosed because they are not correct. So in this scenario, what should we be doing? If you look at the average statistics of the country, only 5 to 20% of patients in India undergo a routine and a regular HbA1c test. And this is data from Dr. A.K. Pondicherry. With the dearth of accredited labs and limited resources, use of HbA1c as a diagnostic test in India is questionable. So we have to rely on both the fasting and post-tracking. In an unorganized health sector, from rudimentary primary health centers to high-tech corporate hospitals, it is very, very difficult to standardize a test like HbA1c all over the country, even for monitoring glycemic control. When we have not been able to standardize education, how can you standardize this test? Even for monitoring. If you look at the trend of collection centers, I don't know what is happening in UP, but in Bihar and Jharkhand we are seeing that people have opened up farm-type shops just to collect blood and send it to the higher center. Now this is leading to prolonged exposure sample at room temperature and a lot of free analytical errors. For monitoring of glycemic control, as Dr. Anil Virmani very rightly said, we should be fixing fasting plasma first and then look at the post-tracking. To conclude, friends, as clinicians and scientists, we should not be concerned what is correct. Is it blood glucose or HbA1c? Which is the most correct measurement? Because if we start fighting between these two, it will be like a person having 2 watches and they are not being able to tell the right time. Instead, we should consider the multiple measures as containing complementary information and each telling us something unique about the patient. And we should be using this information as an opportunity to better understand the pathophysiology and raise the confidence we have in individualizing treatment for all patients with diabetes. Thank you. Have a nice day.
Thank you, Dr. Virmani, for your excellent.
I request Dr. Pramod Gupta and Dr. Ashok Agarwal.